All right, Kyler, take us away.
Okay, let me go ahead and share my screen real quick. Okay, you should be able to see my screen, hopefully. PowerPoint. Okay. All right, so, okay. So as was mentioned, my name is Kyler Sherman-Wilkins, and I teach and I do research on health and health disparities specifically, and I focus on older adults in particular. And really what I want to do is have a conversation about what's really going on in the ivory towers, in the research labs, and discuss a little bit about what it means for all of you, and also just have a conversation. The really important thing with research is we're basically, those who are interested in health research specifically are drawn to it because they want to know how to make the lives of people better, right? How to ensure the well-being of the entire population. And oftentimes when you have people like me, for example, who is not living or navigating the world as someone who's an older adult, some of these questions may elude me. And so I just really want to get some of your feedback and some of your thoughts as to what do you think researchers should be looking at, particularly as it pertains to aging. Okay. So the first thing I'll want to talk about is what the federal government does and how it prioritizes research in this area. I don't know if anyone has heard of the National Institutes of Health. Okay, so within the National Institutes of Health, Dr. Fauci's really well known now, especially with the COVID-19, but he actually only chairs one organization within the National Institutes of Health. There are various different institutes. There's National Institute of Infectious Diseases, there's the National Eye Institute, the National Cancer Institute. And the one that specifically focuses on research on aging is the National Institute on Aging. And that area really is focused, and that area is really focusing on what are some outstanding questions about older adults, what are some of the health issues faced by older adults, and what, more importantly, what can we do to address some of those issues. All right. So I took a screen capture of their webpage just to give you a sense of what the National Institutes on Aging tries to do. It tries to disseminate information. So that's the health information indicator here. It provides news and events. But what's really important for me is this tab on research and funding. So it's a chief funder of all of the research on health and aging from the federal government. And the idea here is to really, incentivize researchers from taking the time to address questions that will allow us to address unique challenges faced by older adults. And the other big piece I think is important to highlight here is that the number one priority for NIH and NIA right now, as it pertains to aging, is research on Alzheimer's. And I actually will have a section on cognitive change in Alzheimer's and specifically what it means for the older LGBTQ population. That's a prime concern and primary area of interest. Okay, so that's the NIA. Now I want to say that part of the issue with doing talks on LGBT aging specifically, and I was actually just talking to Molly about this before when I got on a little bit earlier, there's not a lot of information out there. And this is one of the main challenges facing older adult population, LGBT older adult population, because quite frankly, it hasn't really been prioritized, this particular group. And there are a lot of reasons as to why. The number one reason, quite frankly, is that we as a society have largely been focused, in general, research on aging is not very popular. We are in a youth-centric society. A lot of research, especially within LGBT populations, focuses on youth. And that's important. Youth certainly do encounter a number of challenges, but there are also unique challenges faced by older adults. A part of this focus or lack of focus on older adults who are LGBT stems from this belief that we lost an entire generation to HIV/AIDS, and so LGBT older adults don't exist, when that is certainly not the case. And so there are a lot of pushes. So even though there are a lot of challenges, there are a lot of pushes because there are increased opportunities for funding for older adult research. One of the biggest indicators of this, which is really reassuring to me, is that surveys that collect information on health and aging and employment and marital status, they're now asking questions about sexual orientation, right? So what is your sexual orientation? What is your gender identity? And that allows researchers to, examine what these patterns look like for older LGBT folks, right? So there are a lot of promising signs, and we're moving in a really good direction, but we're not quite there yet. But I do want to highlight a couple of important things that we do know. And what it means. So this information, this is a capture from the results of an executive summary that was written by researchers in 2011. Fredrickson Goldson, who is a leading researcher on LGBT aging. And here are some highlights. So nearly one half of older LGBTQ adults have a disability, and nearly 1/3 report depression. Most LGBT older adults, 91%, engage in wellness activities, right? Almost 2/3 have been victimized 3 or more times. 13% have been denied healthcare or received inferior care. More than 20% do not disclose their sexual or gender identity to their physician. About 1/3 do not have a will or durable power of attorney for healthcare. And most needed services, senior housing, transportation, legal services, and social events. I want to pause here and just get some of your thoughts. As you look over these key findings of this report, what are some thoughts that you have? What are some things that pop out to any of you? If anything, no pressure.
Yeah, one question that I have is when they talk about 2/3 being victimized 3 or more times, is that specifically because of their orientation or it just in general? And how does that compare to those who are cisgendered?
Mm-hmm.
And by wellness activities, what's meant by that?
Mm-hmm.
I don't question any of these. I just, clarification.
Sure. No, that's important. So for victimized, it's broad. It's not necessarily connected specifically to them being LGBT. And that being said, when compared to, so how do they find older? These are individuals age 65 plus. Right. Some studies look at 50 plus. And quite frankly, a lot of studies that look at older adults who are LGBT, they use 50 plus just because they want more numbers. But in this, so the formal definition is 65 plus, right? And we use that as a cutoff because that's when people are eligible for Social Security benefits and retirement, right? That's the general use of that cutoff. So in terms of wellness activities, this is a broad set of things as well. It can include things like going to social support groups. So like the term social daycare is so derogatory, but there are a family of activities that involve like things like this, right? The lunch and learn, gathering together for social events. They could include things like engaging in, bridge groups or bingo groups, any kind of social activity types of things, exercise, yoga, right? So they're a broad collection of particular. So it's not a bad thing, essentially, right? Engaging in wellness activities is actually a sign of engagement and being good. And in terms of victimization compared to individuals who are cisgender or heterosexual, by and large, LGBT older adults are more likely to be victimized, right? So in comparison, as a social group, they have higher rates of victimization, right?
I have a question. Do you know what is being done in relationship, particularly through Older Americans Act funding or some other source, to the training of nursing home and assisted living facilities related to their knowledge about dealing with LGBT people?
Yeah, so that's another hot topic right now, area for research. I can't speak specifically on the particulars as to what's the dollar amount or what's the priority in terms of ranking, but independent researchers certainly do factor in it and look at and try to examine what are the benefits of having inclusive LGBT curricula in medical schools and how that might translate to better practice. So from the researcher standpoint, it's what are the benefits? And obviously a layperson can tell you, yeah, it makes sense. It's really good if, healthcare workers have the cultural consciousness to be able to engage adequately with sexual and gender minorities. Now, the NIH typically doesn't implement policy, it rewards research. And so we do the research and then we pass it on to organizations like Promo or SAGE or the Glow Center to actually engage in these types of trainings.
Thank you.
Eugene, at the end, I'd be happy to share a little bit about some plans that we have at Sage of Promo Fund to that exact piece about training aging care providers, but I'll wait till after Kyler's finished with his presentation.
Okay, that would be good. Thank you.
Yeah, but good question.
I have been in the field of aging gerontology for 50 years. I'm just recently retired, and I've always, it's a fine line. You know, we in this country tend to categorize people: old people, young people, black people, white people, red people, rich people, poor people. And I'm always, thinking we should do more for LGBT people who are older. There's very little being done specifically for them. But on the other hand, even though I was in charge of those types of older American Act funded programs, I hesitate to say, let's do something or promote something specific for them in the nursing home or assisted living centers, because there again, we pull them away from the major mainstream of society.
Absolutely, absolutely. And a lot of the sociological explanations for determinants of health are rooted into how resources are distributed, things like stigma, things like acceptance, whether people are, are they seen as being human beings? And so that categorization on the one hand is, no one, we want to see people as people. But at the same time, when it comes to health intervention from a standpoint, you have to understand what each of those different social groups go through and what are their unique challenges to be able to address it. I do want to point out what JMO typed. Yes, I can include the report if you want to see some of these data. There are a number of studies that show higher rates of disability among older adults. The reason why I wanted to show this slide in particular is because I think it's also important to note that a lot of focus when it comes to looking at marginalized groups tend to focus on the detriments. What are some of the negative aspects of being older and LGBT? But there's also a story of resilience here too, right? As I mentioned, 91% of older adults who are LGBT are engaged in wellness activities. 82% of individuals report moderate to rigorous physical activity, right? So, and when we're looking at these numbers, 1/3 report depression, there's 2/3 that do not report depression. And so a lot of the research, I think it's really important is to focus on the resilience, focus on the heterogeneity or the variance that exists within the older adult LGBT population. It's not a story of sadness, it's a story of resilience in the face of a lot of hate and structural barriers. So that's what I wanted to really articulate with this slide. Are there any other questions or thoughts before I move on? But I can certainly provide some of those data and some of those studies. I can send them to Molly for dissemination. But yeah, there's a lot of, I shouldn't say a lot, but there's a robust research that shows higher rates of disability and illness among LGBT older adults. Okay. Some of the things like having a will or durable power of attorney is also related to things like social support and finances. And by the way, this is spread out across the entire LGBTQ older adult population. So we have, for example, older adults who are, we have Black older adults and Hispanic older adults who are also dealing with systemic racism, right, and other types of things that might make them a little bit more at risk relative to middle-class white folks. So when thinking about older adults, the population, we're thinking broadly of everyone in the population, not just a group that tends to be represented, who have the ability to come to events, for example, like this, right? Yes, it is Age with Pride, right? Okay, so moving on, I want to talk about a couple of things that I think are just the hottest of topics. The first is, does old age equal poor health? Another question I'm going to ask is about what's going on with cognitive aging. And then the third is going to talk about social relationships. And these are three things that get the most attention in terms of funding requests by the NIH. So I wanted to share what we know about those things going forward. So when it comes to health, I'm sure you're pretty savvy on this, but if I were to ask you, how would you define health? What would you say?
Absence of illness.
Okay, absence of illness. All right. Anything else?
I'd probably go the opposite direction and say that the presence of things in my life that enable me to experience physical well-being, emotional stability, and spiritual health, that kind of thing.
Yeah. Well, let's combine both what Eugene and JMO said to come up with our working definition. So this is how the World Health Organization defines health. Now, it does emphasize that the absence of disease or infirmity is a component for sure, but it emphasizes also the state of complete physical, mental, and social well-being. Oftentimes when we focus on removing a disease, and typically we're talking about a physical disease, we're ignoring other aspects that make someone particularly healthy, right? And it also goes back to this idea of the some of the statistics I showed before. While it is the case there may be higher rates of disability disproportionately among sexual minorities, LGBT older adults, that does not say that they're necessarily socially isolated, right? Or suffering from mental health disorders. It's a conglomerate of different domains that classify someone as being healthy or not healthy. Right. So this is the definition that we use typically. And you also notice by talking about physical, mental, and social well-being, it's an entry point for not only biological scientists to study health, but also psychologists and sociologists. So it broadens the contributions of various different disciplines that emphasize different things when talking about health. Okay, so what is health? There's been a shift from what's called the biomedical model, which really concerns itself only with biological factors associated with the disease, and it moves to a biological, psychological, and social model that kind of incorporates all of them together. One thing I think it's important to note about this and why this is so important is that if we operate from a biomedical approach, we're basically emphasizing only biological or genetic differences between social groups, right? So if we're making a claim, for example, that sexual minorities or gender minorities have higher rates of disease or illness, that's tied to biology and genetics. And I think that's an incomplete way of looking at that, right? Because it ignores a whole host of social and behavioral and psychological determinants of health, right? If we have the biomedical approach, we're ignoring things like homophobia and transphobia, right? The different ways in which that might sort people into certain health categories, right? It's known that certain physicians will treat patients differently based on some of their biases toward people who are LGBT, and so based on these perceived notions of what they might need or what they may not need, right? So really this model allows us to address, some of the mechanisms underlying differences or disparities in health, including across sexual orientation and gender identity. So here is just a graphic that shows what these different domains might look like, right? So with the biological domain, you have things like genes and body chemistry, you have stress reactivity, but that's just a part of the puzzle, right? We also have things like learning, perceptions, beliefs, emotions. How do we manage our stress? Those would be psychological types of factors that play a role in health. Beliefs could be things like, do you believe that you'll be listened to if you go to the physician, for example, right? And that's a really big issue for LGBT older adults, right? This is anecdotal, but I have a story of someone who went in, he's an older gay man, and they were asking about his sexual history and like, are you concerned about HIV and AIDS? You don't need to be because of your age. And it was like, what? Like he was really upset by that interaction, and rightly so, right? Not only did it kind of diminish this idea that, he was a sexual being who could still engage in sexual activity, but he had other health concerns that were not HIV/AIDS related, right? But that was a perception and a bias that the physician had, right? Okay. And then social is what I tend to focus on. Social support. Do you have social support? Can you rely on instrumental support? Even the perception of having people around you can matter a lot more than actually receiving the support, which quite frankly is why we see a strong association for, say, being prayed for and health, right? Now, the funny, interesting thing is, if people are praying for you, but you don't know they're praying for you, the health benefits are not there. People are praying for you and you know they're praying for you, there is a benefit. And what does that tell you? Well, it tells you that it's the perception of social support that's operating there, right? Things like education, things like access to health insurance, right? We live in a healthcare system in which people who don't have adequate healthcare or health insurance don't get the care that they need. And we know that for trans people of color particularly, they have less, they don't have, they're more likely to not have health insurance, right? And that's also linked to class and race, right, and ethnicity. So it's not, it's an intersectional type of issue there, right? So all of those things matter. Cultural conditions, cultural beliefs, right? Those also matter for health, right? I grew up eating soul food, not the best for health, right? Not the best for health. Okay. So this is just talking about where the entry points for different researchers are. A lot of the focus on health within the domain of aging is what probably is obvious to all of us here, is that old age is not synonymous with poor health. There are people who age very well and live for a very long time disease-free, and not only disease-free, but also in complete physical, mental, and social well-being, right? So that's the bottom line there, is that it is not equal to poor health. That being said, increased age is a predictor of poor health, right? Because of the natural changes to our bodies, we have a higher risk as we get older, but in no way is actually synonymous to poor health, right? Age is not a disease. The aging process is not a disease. Okay, so what happens to cognitive functioning over time? This is another big area. Alzheimer's is currently the 6th leading cause of death. But that's also kind of an interesting number, because there are a lot more deaths that are attributed to Alzheimer's that are just not proclaimed as much because it's not the primary cause of death. The other important thing to note about Alzheimer's is that you can only diagnose it posthumously, right? And so as a result of that, the number of people who actually die with Alzheimer's or complications due to Alzheimer's may be undercounted, because physicians have to have a reason or a speculation as to why. And also sometimes families do not want full-on autopsies, right? My grandmother passed 3 weeks ago, for example, and we made the decision to not do an autopsy because we know that she had kidney failure. But there could have been some complicating features of Alzheimer's as well that we don't know because we didn't perform the autopsy. So anyway, Alzheimer's disease and cognitive functioning is a very important area, not only for patients themselves, but also caregivers and loved ones. So what is the consequence of having a older adult population in which cognitive decline and Alzheimer's are expected to increase in the next couple decades. I just want to briefly say what cognition is. It's the vast array of mental processes that occur in higher organisms. And like I said, they're vast, right? Things like obviously attention, memory, those are part of cognition. But even like being able to stand and balance, that is a function of cognitive ability as well, which is why when we look at falls among older adults, that's linked to cognitive decline, right? Visual, spatial, processing speed, reflexes, that's all tied to cognition as well. So what happens to cognition? Here are different domains: attention, learning, memory, in which there's short-term and long-term, intelligence, of which there's fluid and crystallized. There's also processing speed, as I mentioned before. So all these different types. And the reason I point out these different domains, it's important because not all of them change the same, or not all of them have the same patterns as people get older, okay? I do want to go ahead and make sure that I acknowledge differences in terms of memory. There's both declarative and implicit. The declarative is what you actually call upon and summon to do some kind of task. So working memory would be, for example, if you are currently involved with one task and you have to do something else and have to remember what you're doing and recall that information. A good example of this is the way we test for this, by the way, is we ask people to take a number, like say 69, and subtract 7 from that number, and then subtract 7 again, and then subtract 7 again. So it's a working memory. It calls for you to hold on to a piece of information and remember when you're doing this various subtraction. Episodic memory is remembering specific episodes, events, and semantic memory is feelings and things of that nature, things that are more vivid in terms of, like cultural tradition, those kinds of things, right? And then there are implicit types of memory as well. These are more automatic. Procedural memory, for example, would be, when you jump on a bike, if you know how to ride a bike, you don't have to think to do that. Or if you're doing some kind of complex operation that you've done for, years and years and years, it's kind of automatic. Fluid intelligence, this is the capacity to process novel information, right? It's not really influenced by prior learning. And so when we're thinking about how do we measure fluid intelligence, decline in both verbal and performance measures of fluid intelligence is one way. And we see a classic aging pattern with intelligence and with fluid intelligence, and I'll show you that in a second. It's really important to note that when it comes to intelligence generally, some evidence suggests that these changes are modest, and it really depends on what domain of cognition you're talking about. And also that only occurs at advanced ages for many people. Crystallized intelligence is different. This is based on information, skills, and strategies. In many ways, this gets stronger with age, right? This is maintained, or at the very least, it's maintained at older ages. It reflects accumulative past experiences and socialization, right? Practical expertise in everyday life, peaks in old age. A good example of this is vocabulary. This is something that tends to increase or at least stays the same. Some people conflate crystallized intelligence and wisdom to be the same thing. Others make distinctions, but the point here is that we associate, experience based on lived experience, or based on practice in the accumulation of experiences as being important and something that older adults have more than younger adults, just as a function of them being alive longer. So this is what happens to various different domains of cognition over time. And so we have on the, on the x-axis age. So as we from 25 to 81, and then we have the mean scores. So these are average scores for a group of people at different ages. And this is what happens. And each of the different domains of cognition are indicated by a different, symbol or color. If we look at, for example, verbal memory or verbal ability, rather, that's in the square, kind of like bluish indigo, I guess, color. Note that it goes up. It peaks from 25 to 39. It goes up. And then it largely stays the same across. It becomes pretty stable. So that would be an indicator of crystallized intelligence, right? Numeric ability, kind of fluctuates a little bit, but it's also remains pretty stable. We don't see dramatic declines for numeric ability. That would include things like addition, subtraction, right? But we do see pretty steady declines in all of the other domains of cognition, right? And the thing that I point out to my undergraduates when I teach at college, who are 21, I say aging begins at 25, or aging begins at birth, quite frankly. But if you think that your brain, you're at age 25, your brain is fully developed, and at that point you decline, right? Quite frankly, with a lot. And so the decline is gradual, but it is steady, right? So things like verbal memory, forgetting words, perceptual speed, you might take longer to read or process certain information, inductive reasoning, those things decline over time, right? Now, these are averages, which means there are going to be some people who maintain high levels and don't have significant declines, and others that have very dramatic decline. The other thing to note about cognitive aging that's really important is that some degree of decline is going to be normal and it's expected. It's a normal part of aging. So forgetting where you put your keys, forgetting to pay a bill, right? Those are things that happen. They'll happen probably more often at older ages, but those are considered normal types of declines. When we start getting into preclinical and mild cognitive impairment, that's the MCI, that's when we start getting into activities that actually alter our ability to care for ourselves, right? Or make it dangerous to live independently, right? Things like leaving the gas on, things like forgetting to turn off the oven. We start seeing an inability to live independently, for example. Oh, so perceptual speed. Yeah, that's reaction time or perceptions in general. So time it takes for you to see or a stimulus to be exposed to you and for you to actually process it, right? So a prime example is if you're driving down the street, a cat runs out, how long does it take for you to swerve out of the way, right? That's a good question. And then, of course, dementia is pathological cognitive aging, right? That's when we start getting into neurological damage, neuronal death, right? But the point here is that everyone experiences decline. The goal is to ensure that decline stays in that, green or light blue range, right? We know that there are disparities across groups for cognitive impairment. There's not a lot of evidence, or I can't say anything definitively about how this is patterned across sexual orientation or gender identity, but it is patterned across race. It is patterned across ethnicity, where we see that higher prevalence of cognitive impairment experienced by Black and Hispanic individuals, right? There is some evidence, some preliminary evidence that older LGBT adults, especially those who are exposed to certain levels of stressors lack of physical activity, those types of things might be at more increased risk, right? And the reason why it's not so difficult to make that kind of prediction or to project that way is because we know that stress, chronic stress in particular, has been linked to higher rates of Alzheimer's disease. And we do know that there are a number of older LGBT, older adults who have accumulated an entire life of chronic stress. And so if they don't have the resources or social support to be able to deal with that stress, then that puts them at an increased risk for a number of diseases, including cognitive impairment or Alzheimer's. So a lot of this is theoretical. The question is, we need to investigate this. And that's why it's really important for NIH and NIA to continue to fund some of this research so we can have definitive answers as to what the patterns actually look like. The last one I want to talk about before kind of opening up for questions and discussion is, how do social relationships change over time? Right? This is another big question. And as a sociologist, this is one that I'm particularly interested in. A lot of my work looks at things like social isolation, loneliness, and what does it mean for health and well-being. And I want to define a social network because I think this is a really important takeaway from this. So social network is a set of relationships, basically these dyads that connect people. And if you look at research on social networks, it actually looks like a network. You have these different nodes that are tied together by these different lines. And these ties are simply connections between two people in a relationship, and they vary in strength. So you can have weak ties that are not overly important, and also strong ties. These strong ties are family, they're close friends, they're loved ones. These weak ties could be your barista at a coffee shop, or the sandwich artist at Subway. People that you have these interactions with, but they're not as meaningful. And we know, compared to heterosexual cisgender adults, LGBT older adults have fewer options for informal care, which ties into social relationships, social networks, social capital. We know that LGBT older adults are more likely to be single or living alone, and less likely to have children to care for them. Now, why is the children point so very important, do you think?
Well, I can speak from experience. So my dad is openly gay, and I was raised by a single gay parent, and I know that we are really lucky that my sister and I are able to care for him. And this past year, his health has taken his physical health has made a sharp decline, and I often find myself wondering, what would happen if he hadn't have raised us. So we're not biologically related. It's a long story. And so I just think about sometimes, like, wow, if we didn't have each other, I truly don't know what he would do. And we talk about that all the time. And so I definitely don't take that for granted. I take my caretaking role very seriously, and I'm honored to do it. But he does have connections and friends in the community who don't have offspring, who don't have younger folks in their lives to help navigate just the systems and everything.
Yeah, absolutely.
And I'd like to add that I'm lucky that I have a daughter that wants to care for me. In fact, she's wanting me to come and live with her. And I don't feel like I'm really ready for that yet, but if I really need it, I might take her up on it,
And Charlotte, I like what you mentioned, because it really gets into this idea of the receipt of support versus the perception of that support, right? Because one of the biggest predictors of longevity is aging in place, meaning staying in your own home, having purpose, having meaning, being able to, be an autonomous agent. And oftentimes the first step in relinquishing some of that autonomy, it involves either moving into an institution or having someone come in to care for you. Because, even though they're doing it out of a sense of love, they're still going to be, guiding you and telling you, oh, you should do this, you should do that, you shouldn't eat this, you shouldn't eat that, right? And so there is a sense of a loss of autonomy. But that perception that you have your daughter there, that knowledge, certainly is protective for sure, right?
And I'm lucky that she's very accepting, and she's married to a man who's very accepting.
Absolutely.
He says he loves me, and
absolutely. Yeah.
Yeah.
And and I think the point there about the acceptance is so very important, because by and large, heterosexual cisgender folks don't have to worry about being accepted writ large by their children and their family. Obviously we can think of families that have, that fall apart for a variety of reasons, but it's more common for LGBT older adults to have families that reject them or no longer have ties to their family. So it really is a blessing or a matter of luck for sure to have that acceptance there, right? But yeah, go on. Sorry.
No, I'm sorry. I didn't mean to cut in there.
No, you're fine.
One of the things I think we forget in our society is human beings' most basic need is to be needed.
Mm-hmm.
And we think, oh, it's wonderful, retire as soon as you can and lay back and fish every day or whatever. And that causes a lot of real problems. And even putting people or people going into assisted living and those types of facilities, it still doesn't fill their basic need to be needed. And, talking about love, I think people forget that love is primarily expressed by action, not words. And I have at least a half a dozen people who tell me occasionally they love me, but I'll be damned if they're ever around when I need them.
Mm-hmm.
And so it's two different things.
Mm-hmm.
And LGBT people generally do not have children. And so they don't have the benefit of having their children and grandchildren occasionally around them. And I think we have to remember that more and more. And I really do believe one of the reasons you go to some of the care facilities and you see older people sitting there in a wheelchair with their heads down, they have nothing else. They have no mental stimulus. They're not surrounded by people who love them. You could have 1 million people around you and still be very lonely.
Absolutely.
Because not one of them love you. I'm sorry, took too much time.
No, this is perfect. I mean, you hit on some really important things, and I'm really happy that you made that distinct. Loneliness is a psychological feeling. It's not, one of the things that I always push back on when I hear oh, that person can't be lonely. Look how many people are around them. Like, yeah, like having that, being surrounded by people is not an indication that you're not lonely. There are people who have one confidant and are not lonely at all. Right. And so I think and that's what makes interventions particularly challenging too, because oftentimes, the solution is like, well, we'll just surround people, make sure they, are part of a community. Well, that part of the community is a psychological process, not just having people who are there, necessarily.
Yes.
Absolutely.
And, filling the basic need to be needed. I've been fortunate that I've lived in some very, very poor countries. And I have seen repeatedly where there were elderly people living in thatch roof huts, sitting on dirt floors, but they had a job to do, either help take care of the baby while mom was working in the field, or shucking the corn so that they could grind it, make tortillas, some little task that made them feel needed.
Mm-hmm. Yeah.
And important to the family yet.
Yeah. There's a really, it's been a while since I read it, so I'm gonna try to get it correct. But there was a study that looked at people who, and it wasn't necessarily older adults specifically, but it was talking about this idea of purpose and autonomy. And what they did is they had patients who had received some kind of procedure, some kind of surgical procedure, and they were looking at recovery times. And they had one group that were given plants to take care of. Right. And they get to choose when the plants are watered, right, when the plants are put in the sun, all that stuff. And you had a control group that had no kind of, nothing, no plant or anything, right, just a bare room without anything. And the people who actually had, a purpose, namely caring for those plants, actually had faster recoveries than those that did not. Right. And then you look at studies that look at purpose and mortality. Those who express having a purpose are less likely to, or have lower mortality than those that do not. So it's a really powerful predictor. And purpose oftentimes is linked to our social networks, social groups. A lot of the purpose that people have is in helping other people, right? And so they're intimately linked in a lot of ways. And something that was pointed out by JMO, I love it. This comment. And so in this sense, you have a family of choice, but not because you're replacing necessarily because you have family that's rejecting, but just access to people who are willing to care for you. That's another example of family of choice, right? People who we choose to bring into our lives and who, quite frankly, choose us as well, in a sense, to support us and care for us. So we know that resilient LGBT older adults often rely on families of choice. And it's for a variety of reasons. LGBT community organizations and affirmative religious groups for both care and support, right? So again, this is to show that it's not just it's not a story of sadness, it is a story of resilience, right? Now, we know a lot, but there's still a lot that we do not know, as this photo stock physician shrugging his shoulders is indicating. So there's still a lot that we really don't know. And that really leads, wanted to lead to a discussion and also just kind of like a general Q&A about, where should we go from here? What do we need to know? What are some of the unique challenges that are facing the LGBTQ community on things that need to be fixed? And I can also take this time to just clarify anything that I know I moved through quite a few slides. So if there's anything that needs some clarifying, I'm happy to do so as well.
Kyler, as a person who came out as agender in my 60s, I went looking recently for a support group, a place that I could talk about various issues connected to being agender at this place at this time in my life. Like, I'm hunting for a job. Do I make an issue of my pronouns? It may be hard for me to find a job as an older person who says z's or zers, what, but most of the groups that are out there that are support groups for people on the transgender spectrum tend to be supportive for people that are younger, who are, discussing issues like, will my parents reject me? Am I going to take hormones? Am I going to do something to my body, et cetera? So I've not found a group that I can, talk with so far about my particular life span issues in conversation with being of a non-binary gender identification. So that's a gap that I'm finding, and I may actually be trying to start a group to talk about something like that, because I think it's needed, and I haven't found it yet. So
absolutely, and and I think that's I think in that ends up being how a lot of these groups, these support groups actually are founded or started, is like, I'm not getting my needs met here. And so I think it's beautiful and great. Of course, there are some added challenges with having to organize, but at the same time, I mean, that would be filling a gap that exists, something that you need, and I would imagine other people need as well. So that is really a great thing. And I think you do point, and the one thing I like to note about these things is that those support groups serve a really important role, for sure. And, because there are unique challenges that are faced by trans youth. But again, it gets at this idea that the trans youth issues are the only ones that are important, or the ones that take priority. And one could argue that maybe it's a numbers thing, but, my whole take is, if there's just one person suffering, that's one too many. And there's more often than not just one person suffering and they have similarities into why they're suffering. So, but that's a good point. I mean, I really do think that that's, something that a lot of people who start these support groups find, is that they're not getting the support as they need, right? That's good. Thanks for sharing.
I was wondering if maybe Molly could talk about some of the things that SAGE has done both locally and on a national basis to address some needs.
Yeah, absolutely. So all of this research that Kyler is sharing absolutely informs the advocacy that we do. So it's all interconnected, and we need everyone at the table, and we need all hands on deck. And earlier, Eugene had asked, is there a plan for training aging care providers? I can't speak nationally, but here in Missouri, I'm really excited to share about an upcoming initiative. So they're kind of two pieces. So a little provision that was snuck in under the Trump administration, underneath everyone's nose, when the Older Americans Act was renewed, is that it requires area agencies on aging, which exist because of the Older Adult Americans Act. It requires area agencies on aging to review their policies and procedures and practices for affirming and welcoming any group that has a national resource center. Well, thanks to Cheryl Wayland and the SAGE National work, we have the National LGBT Aging Resource Center. Therefore, LGBT older adults qualify under this requirement in the Older Americans Act. And so we are getting ready to partner with SAGE National and the Equality Federation to start mobilizing older adults across Missouri to engage in public comment periods and engage with their area agencies on aging on these exact issues. I'm also excited to share, and I can't say too much because we haven't actually received the funding yet, but we're in the process of trying to secure funding to do some deep cultural competency and cultural humility work and policy assistance with Missouri's 10 area agencies on aging, and that would last over a period of 3 years. So it's a work in progress. We will share widely when that all comes to fruition. We're actively in the middle of seeking funding to make that happen. And I think, to Kyler's point, that so much focus is put on youth, and I don't mean to diminish that at all. But no one's getting any younger. And we keep seeing more and more people coming out earlier and earlier, and that's wonderful. And the number of LGBT folks in the country and in Missouri is growing. And so we can be proactive now to support and care for our elders today, but also be prepared for kind of the wave of LGBT elders that we will see with each passing year and each passing generation. And so I'm really excited about this work. I can also share, last night was kind of our pilot run, our first trial run of actually doing some phone outreach to LGBT adults across Missouri. So we have about 5,000 promo members across the state of Missouri who are 55 and older who are not SAGE of Promo Fund members. And SAGE of Promo Fund and that email list is where we really distribute a lot of really important information and upcoming initiatives, like everything I just shared. That's the channel that's shared through. And so last night, 3 volunteers spent 3 hours calling 150 folks across the state. We talked to 15 folks and we got 12 folks enrolled in SAGE and as part of the SAGE community. So it was our first go. It went really well. This is going to become a recurring opportunity for folks to volunteer and we really want to make sure that older adults are calling other older adults, because there's nothing like a peer-to-peer interaction. But we also, of course, we welcome volunteers from all generations, but it was our first go and it went really well. I know Charlotte's going to be making some calls on her own this week, not as part of the official shift, but Charlotte's going to be helping out too. So we're going to keep going, and I'm going to make sure you all know about these opportunities, because it's so important to build community, and all this research that Kyler has shared with us, we need that too. And that goes into our strategy and why we're advocating for important change.
I have something to question.
I did too.
So Charlotte, and then Bob, and then Eugene.
Hasn't the SAGE been having those trainings all along for the nursing homes? And Cheryl had kind of created that model, and for a while they were doing those here. Are they not doing those now?
Yeah, so those are still happening, but they're opt-in. They're opt-in, and so each individual nursing home, assisted living facility, senior center, they have to decide that they want it. What's different now is that the Older Americans Act mandates our area agencies on aging to not only receive training, but actually change their policies. And so that's kind of the shift, in that rather than these individual little agencies here and there, our entire aging network is required to model those best practices. So yes, Cheryl, absolutely. Cheryl Whalen laid the groundwork for this in Missouri, 100%. So thank you for naming that, Charlotte. And Dan Stewart helped carry it forward. And yes, no pressure. I have no pressure, right? Yeah, Bob, what were you going to share?
Well, you were talking about the training efforts in general, as far as what training efforts are actually being done or are available to nursing home and elder care centers and so on. And what happened was, at our last monthly membership meeting with Prime Timers, our topic of discussion was elder care, sort of just an overall view of it. And I had come across a video on YouTube that's put out by this organization called Life Elder Care, and also co-sponsored with Lavender Seniors. I think they're in California, but they put out a YouTube, and it's a video, and it's a very good one about just showing what training options are available, at least through them. So I didn't know what resources you guys at Sage have come across on that, but this is a video, and if anybody's interested, I can certainly send you the link to it. It was a very good one. It's sort of a little bit on the dramatic side in some places. They actually reenact some situations that come up with some of the elders in these care facilities. And it's a very good video. So, you know.
Yeah, Bob, you're welcome to send that to me. And when I send the follow-up email to all registrants, I'd be happy to include that.
Okay. I mean, you could take a look at it yourself first, Molly, and see how pertinent it is. But it was just a very good example of one organization that is attempting to educate nursing homes or elder care centers that want to be more inclusive. But see, that's the key right there, of course, is getting them to want to be more accepting and want to reach out. And how do we do that? I don't know.
Just a real quick word of endorsement for the video. It's one of the best I've seen. It's great. Yeah. So well worth a view. So that's it.
Yeah, it's about a half hour long, but it's pretty good. Yeah.
Eugene, did you have something that you wanted to share or ask?
Only I want to tell you that I'm happy to help in any way that I can. Bob Brinkman has my all the information where I could be contacted.
Great.
It's difficult for me to travel because I have an impairment and I don't drive any longer, but I can do anything else. And this
Absolutely. Yeah, no, thank you for that. And Bob, I'll connect with you afterwards to get Eugene's information. And I am a big proponent, now that we've proven that we can do things online, you have my commitment to make sure that any event moving forward, even if it's in person somewhere, that we always have a hybrid option so that folks can tune in from wherever they are, from the comfort of their home, from the safety of their home. Because yeah, we have no excuse for leaving people behind. So Eugene, there will definitely be ways for you to engage. Absolutely.
Thank you.
Yeah, I'm excited to talk with you more, definitely. I also, thank you, Bob. Bob just sent me the link, so I will make sure that gets included in our follow-up. I wanted to just see if Clarissa or Sterling, if either of you had anything that you'd like to ask Kyler or share with the group.
Hi. I don't have any questions. I used to work with Sage a few years ago as an intern, so I just wanted to pop in and say hi. I love the work that you all do, and I love seeing all your faces. And I just want to say thank you, Kyler, for the great presentation and the great conversation. I work with youth now, but my heart has always been older adults, and I do want to go back into this work. So it's just nice to come back and get that perspective. So thanks for having me.
Great. Thank you, Clarissa.
I do most of my work with youth at this point also, but my mom is a life coach, specifically a non-financial retirement coach, and she works like almost exclusively with baby boomers. She is a baby boomer, and so I grew up hearing a lot of research on like aging and things, and as my parents start to get older too, I think it's really important for me to stay up to date. And so I'm really excited to be here.
Great. Thanks, Sterling.
And I do want to comment on a couple things, because the focus on youth, I don't want it to appear as if I'm saying that it's, so obviously it is important, but the other thing to note about youth is that a lot of the research that we do on aging uses what's called a life course perspective. In psychology, it's called lifespan developmental psychology. And essentially you cannot understand older age if you don't understand what happens before. So the really important thing is to understand youth, but understand that they are going to be growing into eventual older adults, right? And so that's where I think the intersection of the age is so very important. I went ahead and sorry, I can't use technology. I went ahead and put a link to a series of publications that uses the Aging with Pride study. And I do want to issue a correction. So there was a question about the age ranges. So it really does depend. The Aging with Care, Aging with Pride study looks at 50 plus. But those results are based on different analyses using different age ranges. So some studies might look, for example, at those age 65 plus, some might look at people who are age 80 plus. It really depends. So that list of publications will give you a sense of what those findings are. There's also an executive report that's a part of that link as well. That has like an overall view, but I just wanted to make sure so the data set collects people in 50 plus, but each of those analyses, it just depends on what the question is and who they're comparing.
Thank you. Mm-hmm. Kyler, can I ask you a personal question?
Yes. I almost said no, but then I thought, yeah.
Well, it's a professional personal question.
Molly, if you want to ask whatever you want to ask, I will answer.
Thank you. Kyler, I would just love to hear in your own words, when you started studying sociology, like, did your interest in aging come first, or did your interest in sociology come first and then you were like, oh wow, aging is where I want to be? Like what motivated you to focus on aging and health within aging and the sociology of all of it? Just like, what's kind of your origin story behind your work?
Yeah, well, the funny thing is I didn't engage in sociology until relatively late. My undergraduate degree is in human development and family studies. And then within that, my minor's in gerontology. I came to aging first. And that I came to health first, I should say. I wanted to be a physician, and then I took organic chemistry, and I'm like, nope, not for me. But I also took a course that was taught by a sociologist on social disparities in health. And a lot of the topics really focused on older adults. Why? Well, because a lot of older adults is where chronic disease is concentrated. And so most of the discussions on health disparities focused on older adults. And, I'm also really close to my grandmother. And, I was really looking to care for, when I wanted to go to medicine, I wanted to be a geriatrician. I knew that I wanted to practice medicine with older adults. So the old age piece was there. And then whenever I graduated from undergrad in human development, I was going to go into psychology, but then I was told by professor, based on my interests, really being interested in health disparities, that it makes more sense to go into sociology. So that's when I went to get my PhD in sociology and demography, which is, statistical study of populations. So I started with aging and health, and then I arrived at sociology late. And so in a lot of my research, quite frankly, I wouldn't say that it's sociological per se. It's a lot more public health gerontology. So I don't publish in sociology journals, for example. So I'm a little less sociologist.
Gotcha. Yeah. You kind of forged your own path based on where you felt called, it sounds like.
Exactly. Yeah. I'm directed more by the questions that I ask as opposed to the actual discipline itself.
Got it. Cool.
Yeah.
Can I just?
Yeah, go ahead, Charlotte.
I was just going to say that I belong to this group that every Sunday afternoon we have a Zoom call, and it's called like the Midwest Intergenerational Lesbian Conference, and we have like old lesbians, and then there's some middle-aged lesbians, and then some really young ones. And we have a call every Sunday afternoon, and there's always a different topic. And a couple of weeks ago, it was aging. And it was really nice because some of these young lesbians were saying, gee, I'd really like to be able to help older lesbians, you know. I'd like to like maybe live in like they were talking about these women's land places, and they'd like to live there and be able to help the old lesbians doing things that they were no longer able to do and things like that. It's funny because there's like a middle-aged group that are like in their 40s and early 50s, and they think of themselves as old, but those of us in our 70s think they're still young. But we do have like 20-year-olds too, who are so glad to meet old lesbians because a lot of them say they'd never met old lesbians before, and we're role models for them. So it's really nice.
You know, Charlotte, you brought up a very good point. Is I'm seeing that we're being able to engage more and more of the younger age groups into the issues that seniors are facing as they get older. That's really a good sign. I mean, it used to be to where, seniors, you didn't even want to think about it. You didn't want to think about what state you were going to be in when you reached 65 or 70, you know. But that seems to be changing, and that's good.
I was also going to say that I was a sociology major.
Oh, nice.
I didn't do anything with it. I worked in libraries all my career, but I was a sociology major.
You're doing stuff. I mean, if you're committed to social advocacy and supporting other people, you're doing it with your major.
I feel like I'm kind of do something with it.
You're a sociologist, Charlotte.
Wonderful. Well,
I was a sociology major. I was going to be a biology major, and then when I found out I had to take a lot of chemistry, I had to laugh when Kyler said that.
Yeah.
That's the reason that I dropped out of being a biology major.
Ooh, yikes. So we have some more humanities focused folks in the room, maybe, at least the three of us.
No, that's social sciences, not humanities is like English.
Well, true. Yeah, no, that's a good point.
I will say this. One of the things that I note is a lot of my undergraduate students will major in sociology, and then they find out that they have to take statistics and methods, and they're like, oh God. And I'm like, well, what did you think? Yeah. So, but it's certainly not chemistry. Let's say that.
Yeah, I was actually going to go to social work school. I wanted to be a social worker, and then I got married, and my stupid husband said, "Oh, I don't think you should go to social work school." So I never did.
Who needs them?
The only reason I'm glad I got married is now because I have a daughter that might take care of me. I didn't stay married very long.
I am currently in my second to last week of my master's degree in social work. And I can say that we are also required to take multiple statistics related classes, mostly focused on evaluation more than anything else though. Something I did want to mention that I think Charlotte kind of brought up unintentionally is I know that statistically speaking, it is more likely for queer women to become parents at a younger age. So I think it's really interesting to see what that population like what aging for that population is going to look like. And just thinking about different familial structures and over time is something that is really interesting to me.
That is a hot topic. And, NIH and NIA, I mean, they do some of this work, especially as it pertains to care work, but family structure, that's something that's been really interesting. There's a lot of work that looks specifically at sexual minority women who are much more likely compared to gay men to, so the idea of sexual fluidity is something that a psychologist, Lisa Diamond, published, where she found that women, by and large, it's more likely that they would have had relationships with men prior to relationships with women. So there's a lot more sexual fluidity in that sense, especially among a certain cohort in which, for example, being a lesbian was a big no-no, right? And also just this cultural push to have children, right? That your femininity was determined by your ability to have babies, right? So there was all these cultural pushes there. So you do have a sizable population of lesbian women who have biological children, right? And so there are really interesting questions there. And the other thing that complicates all of this is when, in a good way, is intersectionality, because the experience of older adults is largely shaped by class, race, immigration status, all of these different things. And so it makes any kind of simple examination of older adults who are LGBT much more complicated, but again, more very important, right? And that's what we're not seeing a lot of, is particularly the challenges that are faced by LGBT older adults of color. That is an area that is desperately needed. And the issue really is, in terms of these surveys, is sample size. We just don't have enough people to make any kind of claims. And so that's where qualitative work comes into play. That's where interviews and focus groups and those kinds of things come into play. But that's a really important part, is like, what does aging look like? Because the majority of older adults don't have children. That's driven by largely gay men. It's, when we look at women who are LGBT, that's different, right? And so there's some intersections there that are really important.
And don't you think that a lot of us really old lesbians didn't even know there was such a thing as being a lesbian when we were young, and that's why a lot of us got married. And
absolutely. I mean, it used to be sorry.
Oh, I was saying nowadays so when younger people come out much earlier, they probably won't be as many when they age that have children, although some of them are having children anyway, or they're adopting or something. So
absolutely.
But there won't be as many of us as us really old lesbians.
It's hard to say, but I think you're onto something. I mean, for one, you got to take into account the different technologies that can be used to have a child, right? There's that. Mm-hmm. But the other piece that I think you hit on is this idea. Women's sexuality has been policed for such a long time. And so you did have a lot of people who didn't come to terms with their sexuality because women's sexuality in and of itself was seen as something that couldn't be talked about or shouldn't be talked about. So I think you're seeing a lot of, but the other piece is that, according to Lisa Diamond's work, women or female in general, in terms of sex differences, tend to make emotional relationships more so than the physical relationships on average. That's Lisa Diamond's work. And that could lead to different levels of attraction to different people at different times, right? Mm-hmm. And so that's how she explains it, but it's a combination of other factors too, right? People are able to come out more because being LGBT is more accepted than it was in the past. And also we encourage young girls more so today than in the past to really, what's the comment? Oh God. And so, it kind of reflects this, kind of lost my train of thought. That was a really funny comment, but in general, it just kind of shows the idea that what womanhood and what it means to be is changing, and embracing sexuality for our young women is something that's more acceptable than it was in the past. So, but yeah, I wouldn't go far to say that it may lead to fewer lesbian women with children, going forward, simply because you no longer need to be with a biological male to have children. But I do think what we are seeing is less of a, having to act a certain way, right? Because it's taboo to talk about female sexuality. This is a lot of fun. This has been really fun. Normally, I'm just waiting for students to come to my office hours, so I actually have like a engaged audience. This is really awesome. So.
Any final questions or comments?
Oh my God.
No. This has been great.
Yeah, I think this is, Charles, between your Lunch and Learn and Kyler's, I think like we're on a good roll. Yeah.
I was nervous,
Thank you.
no joke, because I'm like, who wants to sit and talk about research and data? And but I'm glad.
Oh, yeah.
I think I'm operating from like what my students like versus what the normal person likes. So thank you.
Yeah.
All right. Well, I'm gonna stop the recording. But before I stop the recording, I want to officially say thank you to Kyler, not only for this presentation, but also his commitment to the Sage of Promo Fund Advisory Committee and serving on the Promo Board, and is a board member of the Glow Center in Springfield. So, I know you have plenty of free time, and so this was easy to just slide into your schedule, right? But no, your time and attention to the community is just so special and so appreciated. So thank you, Kyler.
You're welcome, and happy aging, everyone.